on to the purpose, we need to provide comfort to the patient, which is the most important thing, to relieve the pressure on various aspects, to prevent any pressure source, to improve circulation, to prevent any formation of deformity, because in a longer period, some kind of deformity or atrophy happens. And because of that, we need to shift the patient from side to side or whatever position that we need to do. To carry out any investigations, any surgical and medical investigations or interventions, as I said, to prevent any pressure source, to provide proper alignment of the body, to prevent any flexion, extension, and also to conduct delivery and labor, and also carrying out nursing interventions. The principles is that we have to maintain a good body mechanics, to obtain assistance as required, ensure the mattress is firm and level of the bed is at working height, because it should be comfortable for the team members also to keep shifting the patient. To ensure that sheets are clean and dry, most important, to prevent any contamination or infection. Avoid placing a body part directly over another to prevent pressure. And also to have a plan to regularly position the patient from time to time over the 24 hours. Ensure that the patient is comfortable, and you should always wash your hands before and after the procedure. So now going on to the different types of position, the most common is the dorsal position or the supine position. Then the next one is the prone, lateral, Sims position, Fowler's position, lithotomy position, knee chest position, the dorsal recumbent position, and Trendelenburg position. We'll go through the slides accordingly. So the first thing we need to do is that we have to check the patient's general condition, check the patient's consciousness, like the GCS, how's the patient is the patient cooperative or not, and what are the physician's order. We have to assess the self-care ability if the patient can take care of himself or herself accordingly. Then arrange the comfort devices near the bedside, identify the deformed extremities, like support the immobile area during positioning, and we should also form a rationale why we need to do the positioning from time to time. The equipments needed are this, that extra manpower is needed. Normally 2 to 5 people are normally required to shift the patient. Then extra pillows, mattresses, the bed should be adjustable. Bedside rails to prevent any incident of the patient falling off the bed. Then sheets and sheet rolls. The comfort devices such as backrest, footrest, bed, cradle, cardiac table, sandbags, hand rolls, and other comfort devices are also present. The procedures that the first thing we need to explain the patient, and if the patient is not cooperative or not conscious, we need to explain the relatives of the patient upon the importance of positioning. Hand washing. We provide a privacy to the patient, we do a screening. Then we arrange the equipments and manpower needed, untie the bed sheets, we turn, lift or ambulate the patient gently. We also place and support with extra pillows under the pressure points, like the shoulders, the knee point and the iliac crest regions. Then cover the patient with a top sheet, and also we should record the time, the position, and the condition of the skin. So we have to do a thorough examination also of the skin condition from head to toe. So the positions are supine position. So here we see the patient lying down in supine position where there's a head pillow. There, the hand rest and also pillow in the knee region, lifting these pressure areas to prevent any pressure source. So the patient lies on the back with the head and the shoulders slightly elevated. So the devices that we need to do the supine position are the pillows, the hand rolls as we have seen, or the armrest, and the footboard. So this brings about a comfortable position for the patient. So examination of the head is done, the neck, the chest, the abdomen, and the extremities as well. And most of the time, the surgeries of the anterior part of the body is done in this position. The complication in this position is that we have flexion contractures. Most important is the peripheral nerve injuries, like the brachial plexus are being affected, like ulnar nerve, radial nerve, then foot drop being the peroneal nerve, and also the pressure source. To prevent these complications, we need firm supportive mattresses. Then we also need pillows we place in the shoulder, the neck, and the hands. And we place roll towels or small pillow towels to maintain the lumbar lordotic curvature. We also can place trochanteric rolls or sandbags along the sides of the hip and the upper half of the thigh. Use a footboard or improvise firm pillows. So most importantly, to prevent pressure sores, we use all sorts of pillows. Now next, the prone position is another one where the patient lies down on its abdomen. So we say the patient lies on its abdomen, but actually the abdomen should be free. Accordingly, we can see it right here. So here there's a pillow in the head, then the pillow in the iliac crest, and the pillow in the knee region, in the lifting the shin and the ankle. So this area where the abdomen is free, so that the patient can breathe comfortably and there's no increase in intrathoracic or intra-abdominal pressure. Also, the patient turns to on one side with their arms also extended, but should not be abducted more than 90 degrees to prevent any peripheral nerve injury. So in the prone position, a patient lies on the abdomen, the head is turned to one side, and the hands held in a very comfortable position. So as we have seen, pillows may be placed under the head, and place a small cushion under the patient between the end of the rib cage and the upper abdomen, so that proper respiration can occur without any obstruction. So when do we use prone position? So we use prone position when we try to examine the posterior tongue, the spines, or the rectum, surgeries of the back, also to relieve any pressures on the areas such as the sacrum, the scapula, and the heel. The complications in this position is that we can see airway-related complications, and especially if the patient is intubated. So there's also, a patient can have, dislodgement or any kind of obstruction in the ET tube. There can be facial and eye injury. In this position, the most common thing is that the perioperative ocular or visual loss can happen as well. Hemodynamic changes can happen, pressure sores can happen, medical device dislodgement, as I said, nerve palsies can also happen. Like in this position, like femoral nerve can also be obstructed because the patient is in prone, so we have to take care of that as well. Fractures and dislocation also. Next is the lateral position. And we can see that the patient turns to one side. The head is being supported by the head pillow. There's an additional pillow where the patient can place his hand. This is the dependent hand. This is the non-dependent hand. And the non-dependent leg is being flexed over a pillow. So this is what happened. There should not be any obstruction in the lower or the dorsal or the ventral rib cage so that the patient can breathe easily. In the lateral position, the patient lies in the side position. The patient lies on one side. Major portion of the body weight is on the dependent hip and the shoulder. The use is that we can place this position for the patient and the patient becomes comfortable. It relieves pressure sore on any bony prominences. It is used for enema insertion of the suppositories as well and for checking rectal temperature. Thoracic and renal surgeries also can be done. Here also we should take care that the arms are not abducted more than 90 degrees. The complications is that we have to prevent the complications by placing a pillow under the neck and the head to prevent the lateral flexion of the neck because inline stabilization should be needed. We also can place a pillow under the upper arm, lower arm, to prevent any further flexion. Hands wrist splints can be placed. We can also use one or two pillows as needed to support the leg. And we also try to ensure that the shoulders are aligned with the hips. So any flexion or extension is not there. Next is the Sims position, where we can see that the patient is also lying down in the abdomen, but it's a little different from the prone position. So this differs also from the side lying position. The weight is placed in the anterior ilium, humerus, and the clavicle. The patient lies on one side with the same side arm drawn behind the back, and the other arm may be in any comfortable position. Can we move back to the previous slide? So we can see that one arm is drawn straight and the other arm is in a very comfortable position. So the uses that we can use for vaginal and rectal examination to relieve pressures in the buttocks, scapula, and the heels. So these are the exposed areas. So there's no pressure source in these areas. Next is the Fowler's position. It's an upright position with the patient in sitting position in the bed with legs resting on the bed. So the legs are in the bed. So there are different types of Fowler's position. We can see now the lower Fowler's position is at 30 degrees. The semi-Fowler's is 40 to 45, and the high Fowler's is 75 to 90 degrees, as we can see in this diagram. The comfort devices needed is that a backrest is needed to support the back of the patient. The knees may be raised by pillows, and arms are also can be supported by the pillows by the side of the patient. So as we can see here, the arms can be supported, the neck and the head can be supported. And the uses of these positions is that it facilitates drainage of the abdominal cavity. It also helps the patient breathe more comfortably. It relieves tensions of the abdominal sutures also, and facilitates eating, reading, watching of TV and other things. It also relaxes large muscles of the back. So can we see the patient looks very comfortable in this position. Next is the orthopnic position, also known as the high Fowler's position. Like in the 90 degree, the back is supported by the backrest. And over table placed in front of the patient, as we can see here, the patient can rest with both the hands over the bed table and supported by the pillows, and the patient can lean forward over the table. So here, the respiration is also being aided in this manner. The indications that the patient with severe dyspnea can use this position. In cardiac patients, positions for thoracocentesis, and patients with chest drainage. Like in pneumothorax, hemothorax, this position is very comfortable. Next is the lithotomy position. So lithotomy position is where the patient is supine, but the hips are being flexed at 80 to 100 degree, and the legs are being abducted at 30 to 45 degree. These are the stirrups where we hold the legs into place. The patient lie on their back, the legs are separated, and the thighs are flexed on the abdomen. The buttocks are kept at the edge of the table, and legs are being supported by the stirrups. It provides maximal exposure of the genitalia. The only problem is that when we lift the legs, we should lift them simultaneously so that we prevent any extreme torsion of the lumbar spine. The uses that we can use in vaginal examination, the pap smear, position during delivery, and also any surgical procedures of genitourinary system. Next is the knee chest position. As we can see, the patient lies down in this manner. The scapula has been assisted. So the patient lies in the bed in such a way that the knees and the chest rest on the bed. The head can be turned to one side. A small pillow can be placed under the chest, and the weight of the patient rests on the chest and knees only. So the abdomen and the abdomen is free. The knees are flexed and the thighs are at right angles to the legs. So we can see in this manner. We use this position for examination of the rectum and vagina, and also for postpartum exercises. Next is the Trendelenburg position. So in the same way, this patient is lying in a supine position, but the only difference here is that the head is tilted downwards. This is the Trendelenburg position, and this is the reverse Trendelenburg position. And also, we also need straps so that the patient will not fall off the table. Trendelenburg position is that the head of the bed is lowered and the foot is raised in a straight line. The patient lies on the back. Beds are available with electric control systems so that we can tilt the patient accordingly. The reverse Trendelenburg position, where the head end of the bed is raised. So in this Trendelenburg position, the complications or the physiological response is that the cardiovascular system, there's increase in the venous return and this increased output, but the respiratory might be a little compromised because the diaphragm moves the fillet, and because of that, the functional residual capacity of the patient is decreased. Functional residual capacity means that the volume of air which is present in the lungs after a normal or passive expiration. So this decreases because the diaphragm moves upwards towards the head side. The uses of Trendelenburg position is that it promotes venous circulation and venous return to the patient with poor peripheral perfusion, as I said, postural drainage, and also an OT for the examination of the pelvic organs. Next is the dorsal recumbent position. The patient lies on the back, knees fully flexed, and the legs are separated. The thighs are flexed and externally rotated, and the feet flat on the bed. The pillow is placed under the head. So we can see here, the knees and the hips are being flexed, whereas the patient is also in supine position with a headrest. The uses of this position is that it helps in the examination of the vagina and the rectum, for catheterization and care, and also for doing procedures in the rectum, vulva, and vagina. So these are the different pictures showing the different positioning. This is a prone position, as we've talked about, the patient lies in the abdomen. Supine, where the patient lies in this normal, where the ventral side is upwards. The right lateral recumbent, where the patient lies on the right side. This is in the left side. Fowlers, like we talked about, the low, the semi, and the high, depending on the degree of angulation or the patient being propped up, and the Trendelenburg. The most important position in the COVID era has been the prone position, and it's been one of the rescue therapy for severe ARDS. So now moving on to the ARDS topic, I would like to call my colleague, Dr. Vivitya.
Good afternoon, everyone. So having learned about the different positionings that we use in the day-to-day clinical practice, now we shall be going to detail regarding prone positioning and its significance in ARDS, or acute respiratory distress syndrome. So in this class, we'll discuss briefly about what is ARDS, the pathophysiology, the physiology and significance of the prone positioning. And then lastly, we'll talk about, we'll show you the practical demonstration. So coming to what is ARDS, or acute respiratory distress syndrome. It is defined by Hansen and Fletcher and et al. As syndrome of acute and persistent lung inflammation with increased vascular permeability. So it is, ARDS is clinically characterized by acute onset of severe hypoxemia with a PF ratio, or the PaO2, and the FiO2 ratio of less than 300 millimeter mercury, with chest X-ray showing bilateral infiltrate and no evidence of cardiac cause. So ARDS is can be caused either by the direct injury to the lung or indirect injury. Direct injury can be in the form of pneumonia, aspiration of gastric contents, inhalational injuries, lung contusions, etc. And in indirect lung injury, we have the sepsis, massive blood transfusion in the form of, you must have heard of TRALI, or transfusion-related acute lung injury. Then we have drug overdosing, And of this, the most common causes are pneumonia, aspiration of gastric contents, and sepsis. It is also classified based on its severity, that is based on the PaO2 and FiO2 ratio. Mild, this is according to Berlin's criteria. In mild, the PF ratio is 200 to 300 millimeter mercury, moderate 100 to 200 millimeter mercury, and in severe, it is less than 100 millimeter mercury. So the pathophysiology, coming to the pathophysiology of ARDS, it is described in 3 stages or phases: the exudative stage, the proliferative stage, and the recovery stage or the fibrotic stage. So the exudative stage, following the following the initial insult, what the lung response to the initial insult is the exudative stage. It usually occurs in the first 24 hours and may last for 7 days. In this, there is activation of the innate immunity, where there's alteration or damage to the epithelial and endothelial membrane of the alveolar capillary membrane, leading to increased permeability of the membrane, and then there's accumulation of protein-rich edema fluid. In this, there's widespread inflammation due to release of many inflammatory particles. So in the proliferative stage, it starts from the 7 to 21 days, and it is the lungs' attempt to re-establish the damaged epithelium, and the lung tries to repair the alveolar architecture, and there is absorption of edema. But at this stage, there is poor compliance. And in most of the patients, usually progress to a recovery stage or resolution stage from proliferative stage. However, in a fraction of patients, they may progress to fibrosis, and there may be increased ICU stay, increased duration of mechanical ventilation, and mortality. So, and typically the lung function is the worst during the first 0 to 48 hours, and it may last for up to a week. So how do we manage ARDS? So managing ARDS lies in treatment of the underlying cause. So we have to treat the underlying cause. Example, if you have a septic foci, you have to treat the sepsis. And for ARDS, we give lung protective ventilation, in which we give low tidal volume with adequate PEEP. And we have to maintain normal volemia. However, in severe cases of ARDS, it's characterized by low pH. There is hypoxemia, can be hypercarbia, and airway pressure can be increased. Standard therapy may fail. So in these cases, rescue therapy is required. So in rescue therapy can be in the form of prone positioning or ECMO. So today we'll be talking about prone positioning. So what are the indications of prone position? According to the Capital Health prone criteria, a patient who meets the Berlin criteria of ARDS with FiO2 of less than 200 millimeter mercury, and it's less than the stage of the disease is less than 48 hours. So what are the indications, what are the contraindications? So, we have relative and the absolute contraindications. In relative contraindications, these are elevated ICP or intracranial raised pressure, intestinal ischemia, obesity, and recent abdominal surgery. Absolute contraindications for the prone positioning. In this, we have spinal cord instability, unstable fractures, then anterior burns or open abdomen, increased abdominal pressures, and unstable pelvic fractures. So coming to the prone position, positioning, per se, what is the physiology behind and how does it help in ARDS? So this image, this is showing the different lung zones in an upright posture. So as we see here in upright posture, there is more perfusion is happening more in the zone 3 or the dependent area, and ventilation more in the zone upper region or the zone 1. So in prone positioning, what happens is we have a homogeneous distribution of perfusion and ventilation. So it improves the VQ mismatch. Improves the VQ matching. VQ means ventilation perfusion matching, and it may improve the oxygenation. So in this picture, we see that this is a CT scan picture of the lungs in supine position and in prone position. So what happens in supine position is, with the patient in supine position, you have the heart and the mediastinal structure pressing on the dorsal part of the lungs, as you can see from this image. And also in ARDS, we have the lungs, the ventral part of the lungs, which are already edematous and heavy comparing to the normal lung. It's pressing on your dorsal region. So there is mismatching of the ventilation perfusion. So from supine to prone, we see that this, now with a patient in prone position, the mediastinal structures has shifted ventrally. Like the heart is now, instead of pressing on the dorsal lung regions, now it is resting on the sternum, and less portion of the lung is compressed. So with prone position, the transpleural pressure gradient decreases, and there is improved ventilation. And also with the diaphragm, also in supine position, the abdominal organs may fall cranially and then collapse the basal lung. So with the prone positioning, what happens is this pressure that is there, it is relieved and the lung volumes increased. And this prone position may lower airway pressure. Relatively, what happens in prone positioning, the larynx, the oropharynx and the larynx falls back anteriorly, and then the pressure can be relieved. And also it helps in the clearing of secretions. And this position can be lung protective. Does it protect the lung? With the patient in the supine position, what happens is there is so much compression on the dorsal region, and with mechanical ventilation, there is over distension because the over distension of the lungs in the ventral region. So there can be from due to over distension of the alveoli. So what happened is in prone position, because this part, the antiventral part is getting compressed, the over distension is limited. Also, because the already collapsed alveoli require more pressure or to open up, so that can cause your atelectic trauma. So with prone position, there can be recruitment of alveoli and reduce in ventilator-induced lung injuries. Prone positioning, these are the nursing care. We have this. We have to before making to put a patient prone, we have to ensure that an adequate sedation and analgesia is provided, and if required, muscle relaxant can be given, and then monitoring. Usual monitoring in the supine position, plus you have to be extra careful to monitor the tube, different medical tubings like the endotracheal tube, so that it does not get dislodged, your chest tubings, and also the pressure points, so that the patient does not develop pressure ulcers. Then blood gas to assist the oxygenation and ventilation. And repositioning of arms every 2 hourly, arms and the head positioning every 2 hourly, and check for the pressure areas 2 hourly. And this positioning can, the duration can be applied for 12 to 16 hours. So before putting a patient in prone position, what are the prerequisites we have to do is, you have to suction the nasogastric tube and withhold the feeding for at least 1 hour. And then you have to ensure that you have adequate personnel, at least 5 person. And then disconnect all the monitors, have necessary medications available by the side, and then all the emergency crash trolley. Then you have the suction catheter, a suction machine ready, and the cushions and for the support of the pressure areas and next. Yeah. So we'll show you the practical demonstration of the prone ventilation. We have videos here, so we'll be showing you videos. I think it's not able to.
I think if the video is not able to play, then we will share you in the WhatsApp group. Next. I think video is not working here. I will share you in the group. Okay, so I think we'll take the previous post. Then we'll do the discussion then. I think thank you, Dr. Dasara, and thank you, Yuki, for the wonderful sessions. And we came to the end of the session. Actually, we wanted to show you video, but I think it's not opening here. I don't know what is the problem. But we will take the discussion now. We will take up your queries here. I have not seen any questions till now. Can you, if you have any queries, can you, these things, either you can unmute yourself and you can ask.
One prone position.
Yeah, one question is there. Yes. Wait. Where is that? Yeah. The color has asked section, how long a patient can be kept in a prone positions?
So normally we try with 2 hours. First of all, the patient can be prone, like after the prerequisites, like ma'am has, talked about. So first of all, we need the patient to be in a prone position with all the pillows, and personnel should be adequate to turn the patient accordingly. We have to inform the patient, and also we have to check if there's no other contraindications for proning. Like if the patient has pregnancy, if this patient is cardiorespiratory compromised, if the patient has any some kind of edema, burns. So we lie down the patient in the prone position, and we can flip the patient on lateral recumbent or right or left, and then back to the supine every 30 minutes for 2 hours. This is the minimum. If there's no hemodynamic changes, or there's no dyspnea, tachypnea, which is the difficulty in breathing or increase in heart rate or respiratory rate, we can increase this proning up to 12 to 16 hours.
I think, Dakaru, we hope you got the answers. If not, you can unmute yourself and ask, okay? By the time we'll take another question, which is asked by Benita. For how long the feeds should be withheld if we want to keep patients on prone position?
So regarding feeding, enteral feeding should be withheld at least 1 hour prior to putting the patient in prone position. After which, like after positioning the patient, you can start your feeding.
Next is prone position, yes.
Okay. And second question is asked by Pinky. Is prone positions for conscious patients too?
Yes, it is for conscious patients also, and then patients who are already intubated and on ventilator.
So that's the topic about awake proning, which the video cannot be played.
Yes. Actually, I will share you that video. Is not opening here. Position, I think during the COVID time, we have done for all patients. Prone positioning was very important.
So prone position, most importantly, is done for patients where COVID is moderate to severe.
Yes.
So which needs oxygenation supplementation.
Yes.
So in this, so it's also like a rescue therapy, like we've talked about. So this increases the aeration or oxygenation of both the ventral lung and the backside of the lung, which is the dorsal lung. That's why it is very important. And homogeneous oxygenation happens, and the patient, improves in this way.
I think during the COVID time, many of you have already practiced in your home also, because so many these things, health workers, even they were, even people who are not working in the hospital also, they were sharing their experience about this positioning and all. And I think you all are health workers, so you must have practiced before also. If anyone wants to share any experience, which you have, you can unmute yourself, you can raise your hand so that at least we also, get some information from you all. So we are happy to hear from you as well. Okay. So another question is asked by Padung, like for how long can we keep the ARDS patients in prone positioning? Oh yes, we have already answered that. Okay, pre-test and post-test we have given. WhatsApp group I have WhatsApp group link I have already shared in the group. You can click there and you can join the group. Thank you so much for such an interesting topic. Thank you so much for your feedback. Okay, network problem I can understand now. The weather is very bad. We can understand even though you try your best to be in the sessions. As my experience, conscious patient cannot lie down in a prone position despite breathing problem. So have to allow them as per tolerate.
That's what we said. Like the patient there should not be any contraindications. And if the patient is conscious oriented and if he understands how do we position the patient accordingly, he can lie down. If there's hemodynamic change of the patient is having any discomfort, then we bring him back on the supine position. So depending from patient to patient.
And also the patient tolerate people. I have not seen any more questions now. Thank you for those who have already submitted post-its link. This one we have already read. Anyone wants to share your experience? You can raise your hand. I think now you can unmute yourself also. Still, we are seeing so many devices with your phone name. Please rename. I'm telling you repeatedly. Otherwise, it's very difficult to count your attendance. Anyone wants to share any experience? I'm not able to see any more queries in our chat box. So do you have any questions? You can ask anything else we have answered. I think session was well understood. Okay, thank you so much. Great session today. Thank you for your feedback. Thank you for submitting your pre-test, post-test. Oh, okay. Yes, we didn't understood. One more question is how long a patient be returned to prone positions after feeding? How long a patient be returned? Yeah, a return to prone positions after feeding. Can you a little bit elaborate? Kanli, can you unmute yourself and can you little bit elaborate your queries? Changing the position. So I've submitted pre-test, posted. No need to write in chat box. We will receive whatever you are sharing. It's very difficult for us to get the questions here. No. No more queries? Thank you. Thank you for those who have submitted. Those who are not able to open the link, please clear your browsing history. Then try to open once again. If you are still having problem, you can personally message me. I'll share you the link. Okay. I think no more queries then. I think no more queries. Then we will. We saw two hand raised by Pamela and Lindsay. You want to ask something? We saw two hand raised. Pamela and Lindsay, you want to ask something? You want to ask something? Jonali, you want? I think it's done. No more. Okay, then thank you so much. Thank you once again, Dr. Vibhuti and Dr. Dasara. Thank you for the amazing sessions. Thank you all the team for making this program successful. Thank you, Bhuneshwar, for controlling the participant. Thank you all the participants for listening whole sessions, having patience, completing your pre-test, post-test. Thank you once again. And those, again, I'll tell you, those who are also joining in the group, please join through your individual devices. Okay? Otherwise, because if you are joining in the group, we will not able to take a group attendance. So those who are sitting in the group, please join individually so that we will take up your each attendance. Okay? Thank you all the participants. Again, we will see you tomorrow. Okay? Yes, WhatsApp link I have shared in the group. If you want me to share once again, I will check and I'll share you. If you don't have any queries, you can leave the sessions, or if you want us to end, if all of you have got the post link, please complete it now. Otherwise, again, if you end the session, you will not able to get the this thing, link. Done. I hope everybody got the post-test link. Thank you. Thank you. Thank you. Sure, we will end the session.
Yeah, thank you. Thank you to all for joining. Thank you.